Okay, so thank you so much to Hep C and the organizers and the reviewing committee. It's a privilege to be able to share. Oh, it's changing on the front screen, but oh, just slow. To be able to share our data and our experience from the last 16 months of using the gene expert in the field within the mobile outreach. So I'm Lindsay Myles. I'm presenting on behalf of myself and Stephanie Alouart from the clinical team of HepCure. So first, an land acknowledgement, just that we are in Quebec City, and this is the land of the Huron-Wendat, but this work is done in Ontario, across Ontario, the traditional Ontario of many nations, including the Mississauga, the Credit, Anishinaabeg, the Chippewa, and the Haudenosaunee, and the Wendat peoples. So, disclosures, we do receive grant funding because we are a non-for-profit through the collaborative grant through Gilead and also through SRX Health Solutions. So we saw in our experience that a lot of patients get lost in that 10 to 14 day period from point of care testing when they are point of care antibody positive, and then by the time they get their dry blood spots. So we were trying to locate these patients in this, their lives are very transient. And so we decided to use the Cepheid Gene Expert under special access approval to help hopefully close in that linkage to care of this difficult patient population. Again, our work is mostly done in the shelter system or in patients that are precariously housed. So it's a difficult population. So we have two units, one in southwestern Ontario, they're retrofitted ambulances. We had lessons early on that the battery power was not enough to run the APC backup of the Cepheid. So we learned that very within 24 hours of getting these machines in the back of a unit. But we now run the mobile unit during the testing in order to keep the power supply. So that's how we've worked around that. So two units. If a patient is point of care antibody positive, we are linked to Connecting Ontario. We do a full review of the testing on history. So if they don't have an RNA on file, or if it's been remote and they need something for chronicity in the last 6 months, we will just take advantage of the Cepheid Gene Expert and run this. And DBS is also done at the same time so that it can be available on the OLIS system. If there is that window period with Cepheid is a much lower level of detection than dry blood spots, so we do serum for the patients that are less than 10 to the 3. So we do provide a monitoring time. So it's what happens to those patients in 60 minutes? Are they going to come back? I think that's the big question. They actually do. We've had all but 7 patients come back and get their result, which shows to me a really high level of engagement of them wanting to know their results. And so regardless of the result, each patient is educated, positive, negative, what being antibody positive means, because there's a lot of confusion with that. And also on harm reduction and risk factors for reinfection. So in that, we take that hour captive to educate patients. So, and if they're positive, they are linked to myself or Steph to discuss linkage to care and treatment. So these are our results. So this is 16 months of data, and this is, again, really evolving. I went through it again 3 weeks ago to see, because we have a significant, that can't be, we have a loss to follow-up. In this patient population, we are treating the toughest to treat. There's a lot of chaotic on and off treatment, but we're still seeing really high rates of viremia in this patient population. Now, we're not doing Cepheid at every patient because of the cost, but we are doing in those ones that we believe clinically are going to be positive or don't have an RNA on file. We engage 66% actually start treatment, and then we do have more complete treatment than loss. But again, I'll also highlight these patients also, the Cepheid, the beauty of Cepheid, if they have partial treatment, we can get in a short time, so they've had partial treatment, do a Cepheid, and see if they're clear on a shorter duration. So it's a way to re-engage them back into care. So again, we're still seeing high rates in this setting. 7 patients didn't come back, but I think that speaks to the power of educating these patients in the time and place and their engagement at that time. And I do think there is even more power in Cepheid in notifying the negative patients that they are RNA negative. In that pregnant patient, I've had pregnant patients that they're pregnant, they're worried about giving it to the baby. Like, Brianna, Cepheid, no, you're negative, you don't need to worry. So that is the power of Cepheid is in the negative patients as well. So we do see we do see a high dropout rate, a loss to follow-up, but this is, again, the patient population, and we can use this Cepheid to our advantage in this patient population and trying to re-engage them, because it's going to maybe take 3 attempts to re-engage them back into care. So it does work even in a mobile outreach setting outside the lab. This machine, yes, we do have errors. We've had some, and with the battery backup, there's glitches, but it is feasible. It works. We've been using it since May of 2023 with pretty good success. And again, it's the education. There is still the barrier of special access approval and upfront cost of the cartridges, which are still a limiting factor in doing this on every patient. And then the next steps, looking at maybe exactly, and anecdotally, this is the first month of treatment, we see a drop off, but maybe looking closer at where patients drop off and also comparing it to the provincial lab pathway. Thank you.
Thank you for a really interesting and audacious bit of work here. Some questions? You have some time? Yeah, Jordan.
Thanks, Lindsay. Great presentation. I was going to ask what the error rate and what the learning curve was, just as we're sort of being able to get this hopefully rolled out very soon, just understanding what your experience was as a user.
It's about, I have the number exactly, I thought I included it. I can't remember, but I will get it for you. It's not as much as what you think.
But one of the things I'm actually curious about is did it get better with time? So that's what we found with some of our studies, and I guess I just wondered your experience and any challenges doing it in the mobile unit and getting enough blood or any other issues?
Because they're doing DBS at the same. They're actually doing it at the same time.
Great.
So no issues with that. The coldness. We had one issue where it was too cold, but that was remotely. Now we know we have to keep those cartridges safe.
Perfect. Thanks.
Anything else? Yes, Mia. Give the last word to Mia.
Really nice talk, Lindsay. I'll try to speak up.
Just for the recording, sorry.
So with the recent approval, I guess I would ask 2 questions. You've been doing it under exceptional access, so probably won't change your practice too much. But how would it change your practice if the province actually paid for the tests?
I would do them on most patients, every patient.
Would you still do dried blood spot in parallel?
If there's a way to record it back to the nice thing, and we all know as providers, it's nice to have that historical. You want to know when they had their last RNA, so I want it on the provincial system. So I wouldn't do.
So if there's anyone in the room who's responsible for getting the province to pay,
Yeah, it'd be nice.
thank you very much.